طيب، بسم الله الرحمن الرحيم. الليلة برضو حنكون مواصلة في المحاضرات حقت هنا السبت والأحد. And today's topic is going to be about major depressive disorder, diagnosis and management consideration. حيكون معنا دكتور بشرى الحسين. بشرى، تفضل.
طيب، بسم الله الرحمن الرحيم. السلام عليكم جميعا. شكرا دكتور ياسر، وشكرا دكتور عبد الغني على organizing this activity، وشكرا للناس الحاضرين كلهم. أنا بشرى الحسين، شغال في Victoria Hospital, London, Ontario. I do general adult psychiatry and consultation liaison psychiatry as well. Our topic today is about major depressive disorders, diagnosis. Maybe if we have enough time, we might go into discussing some of the management parts as well. Okay. Why depression is important, or major depressive disorder? It's a common and a serious medical illness that negatively affects how you feel, think, and the way we act. Sometimes it's difficult to cure, but fortunately, it is treatable. And with that regard, it's the same like other medical conditions. For example, it might be hard to cure diabetes or high blood pressure, but we're able to manage and treat. And the same thing applies for depression. Difficult to cure, but we can treat it unless it's caused by another medical condition. And we can talk about that later. It's a common condition, 1 in 15 adults in any age, any given year. However, some more recent studies indicate more prevalence of depression, even higher than this rate. But the source here is from the APA. 1 in 6 people, which is around 16.6%, will experience depression at some time in their life. According from Canada statistics, it's around 1 in 5. So I thought that Canadians are happier than Americans, but it seems like it's not. It's even higher, but it's close to the same figure. It can occur at any time, but on average, it first appears during the late teens to mid-20s. There is also gender variation. Women are more likely than men to experience depression, which is unfortunate. Some studies show that 1/3 of women will experience a major depressive episode in their lifetime. One thing that I forgot to add is there is some genetic association as well. There's a high degree of heritability, and as I think it was about 40% approximately when a first-degree relatives have depression, like parents, children, or siblings. Again, depression can affect people's life in many ways, but just not to make it very long, I wanted to highlight the impact of depression on employment as one area that depression can affect. Depressed workers have 32 days unable to work in the past year, and that's from Statistic Canada report, which it's almost a month every year, which is a lot, due to absenteeism. 3 to 4 times more work loss days per month, which is approximately the same figure above, but that's from a different study compared to non-depressed workers. And then 2 to 3 times more short-term disability application. People who were not able to attend work and they apply for short-term disability compared to non-depressed workers. And this is from United States Survey of Corporations. So we can see clearly the impact on or burden on economy among depressed individuals. As we discussed in the previous slide, absenteeism, which is known simply people not going to work, versus presenteeism. And surprisingly, presenteeism is a more significant problem than absenteeism. And by presenteeism, we mean reduced productivity when people are still at work. So basically, they're showing up, they seem to be active, present at work, but they're non-productive. Okay. So what is depression? The term depression can be used in different ways, which can be confusing. And it can refer to a mood state, and that could be indicated by feelings of sadness, despair, emptiness, anxiety, hopelessness, having no feelings, or objectively like appearing tearful. Depressed and dysphoric mood may be normal and at times adaptive response to loss as well, as we see in grief, for example, disappointment or perceived failure. In addition to that, depressed mood may be a symptom of psychopathological syndrome or another medical disorder. So that's one definition of depression. It also can be referred to as a syndrome, and which is a group of symptoms or a constellation of symptoms and signs that may include depressed mood. And depressive syndromes that are typically encountered include major depression, minor depression, dysthymia, or persistent depressive disorder, as in the current DSM-5. Also, depression could be or can refer to as a mental disorder that is a distinct clinical condition. As an example, the syndrome of major depression can occur in several disorders, such as unipolar major depression. When I say unipolar major depression, basically I mean major depressive disorder, but it could be part of or present with bipolar disorder as depression part of a bipolar disorder. It could present with a schizophrenia, substance medication-induced depressive disorder, and it could be a depressive disorder due to another general medical condition. Assessment. Major depressive disorders are, as we mentioned, I lean more toward the syndromic criteria, the constellation of symptoms. So diagnosis depends on clinical history and examination with a heavy focus on mental state examination rather than the physical examination, unless it's warranted. And most symptom severity scales used in depression screening do not provide a diagnosis, and that might be a bit confusing. So let me just try to explain this. So when you use, for example, PHQ-9, you can basically, you have the 9 listed criteria required to diagnose major depressive disorder. But you can't really clarify which depressive disorder is present. Is it like with a mixed episode? If there is any bipolarity there, if there is any mania or hypomania, if there is any evidence of another medical condition contributing to the major depressive disorder. So using a scale might help you with just as a first step to dig further and assess the patient more. Or it can help with checking the response and severity of the major depressive disorder and response to medications. So what I want to say here that the clinical interview remain the gold standard for diagnosing depression. History, which is the most important aspect of diagnosis. The patient history should be obtained in detail, and it's common for others, like include the family members or other clinicians, whether that a social worker, psychologist, therapist, or OT, to be involved as well. But we have to remember to obtain consents and maintain confidentiality in case of involving other people. So what are the symptoms that we're looking for when we're diagnosing depression? We look for the criteria, the DSM-5 criteria, which include, I think trainees sometimes use, or medical students use different mnemonic to just memorize the symptoms required to diagnose major depressive disorder. CG or CGCA, one of the well-known mnemonic, but it has only eight letters with 8 different symptoms. Mood is not included, so you have to consider mood first, plus the other 8 characteristic symptoms. Some others use other mnemonic, like my pass ECG. I use that one here. Just the my include M and I rather than M and Y, and then pass and then ECG. Just it's easier to memorize. By mood, we're looking for depressed mood most of the day on most days, and interest, loss of interest or pleasure in most or all activities that used to be enjoyable. And then psychomotor retardation or agitation. And again, it's nearly daily. And usually for this part, the psychomotor retardation versus agitation is not something you could ask about, but it's something that you should observe, or at least observed by others, and it should be highlighted during your mental state presentation. Appetite as well, significant weight loss or weight gain, and that can be measured by 5% weight loss or weight gain within a month, or decreased or increased appetite nearly every day for the period, which is usually we're looking for 2 weeks in major depressive disorder. We also have the suicidal ideations, recurrent thoughts of death or death wishes, or suicidal attempt. And We look for energy, fatigue, low energy, fatigue, tiredness, feeling exhausted, and thoughts of worthlessness or excessive or inappropriate guilt, self-blame. So these are the 9 symptoms. And I like the MyPass ECG because we know that we need 5 out of 9 for 2 weeks. And one of these 5 symptoms should include either mood or interest. So mood or interest should be one of the symptoms in addition to the other 4 symptoms, if it's not more than that. Okay. So that the symptom criteria that we're looking for when we diagnose depression, but in addition to that, the symptoms should cause significant distress or psychosocial impairment. We have to rule out other possibilities like substance or general medical condition causing the depressive episode. Grief, loss does not exclude the diagnosis of a major depressive episode. So if you still meet the criteria for major depressive episode, it's a major depressive episode rather than grief or bereavement. And none of the 9 symptoms that we have mentioned of unipolar major depression is pathognomonic for the disorder. Each symptom can occur in other psychiatric illnesses and general medical disorders. It's more of a constellation of symptoms rather than an isolated or solitary symptoms presentation. In addition, episodes of major depression can vary within a patient or across patients because the combination of symptoms in one episode might differ from a combination in another episode within the same individual. So it's not necessarily for that particular patient to come up each time with the same presenting features. Okay. Being sad is not the same as having depression. And I think I just touched on grief and loss compared to depression. And it's sometimes it's really important to differentiate between the two, although they might happen together. The grieving process is natural and unique to each individual and shares some of the same features of depression. People still feeling low, blue, sad, despair, and so forth. So both grief and depression may involve intense sadness and social isolation or withdrawal from usual activities. But they're also different in several ways. And these ways are important to differentiate between the two entities. So for example, in grief, painful feelings come in waves. These episodes of sadness, they do not persist. They come in waves and often mixed with the positive memories of the deceased or loved person. So when you remember good memories, you might be smiling, right? But when you remember the actual loss, you're sad. In major depression, mood and interest or pleasure are decreased for most of the 2 weeks. So there is more persistence here rather than the wavy, let's say, presentation of feelings in grief and loss. The other point, in grief, self-esteem is usually maintained. In major depression, there is feelings of worthlessness, and which is very common. Also in grief, thoughts of death sometimes may appear when thinking or fantasizing about joining the deceased loved one, while in major depression, thoughts are focused on ending one's life due to feeling worthless or hopeless or undeserving of living, or being unable to cope with the pain of depression and other symptoms of depression. Interesting point that worth mentioning here, that grief and depression can co-occur, can coexist for some people. So the death of a loved one, losing a job, or being a victim of a physical assault or a major disaster can lead to depression. When grief and depression co-occur, the grief is more severe and it can last longer compared to grief without depression. And distinguishing between grief and depression is important and can assist people in getting help, support, and the desired treatment if needed, especially if there's like severe depressive episodes. Risk factors for depression. So depression can affect anyone, even a person who appears to live in a good life, in relatively ideal circumstances, they can have depression as well. So, but there are several factors that they can play a role in depression. Just will go over that quickly. Biochemistry, we know that there's some differences in certain chemicals in the brain. We're talking mainly about serotonin, norepinephrine is involved, dopamine is involved to some extent as well. Genetic factor, as we mentioned earlier, depression can run in families. And I think it was around 40% to have depression if you have a first-degree family member with depression. But with identical twins, there's a study showed that if one identical twin has depression, the other has a 70% chance of having the illness sometime in their life. So there is very high association. Personality can play a role and can be a risk factor for depression as well. So people with low self-esteem, who are easily overwhelmed by stress, or who are generally pessimistic, appear to be more likely experiencing depression compared to other people with no difficulties with these problems, with these issues. Environmental factors, consider the risk factor as well. Continuous exposure to violence, neglect, abuse, poverty to some extent may make some people more vulnerable to depression. So in DSM-5, the depressive disorders that can be diagnosed include, we have many, but they include unipolar major depression, which is major depressive disorder, persistent depressive disorder, used to be called dysthymia, disruptive mood dysregulation disorder, and that's something that we see in younger age among children. Premenstrual dysphoric disorder, substance versus medication-induced depressive disorder, and then depressive disorder due to another medical condition. And there is also other specified depressive disorders, example, minor depression and unspecified depressive disorder. Now, with depression, it's important to talk about diagnostic stability. And patients initially and correctly diagnosed with major depressive disorder may eventually manifest or experience new or modified symptoms that warrants a change in diagnosis. And we see that commonly. I'm trying to look for, I wrote some factors that can predict like a quicker change in diagnosis of depression. I'm just looking for that, and I don't know if I add it here. No, it's not here. Sorry, just give me a second. I put a note of that somewhere here. Anyway, I cannot find that. But what we're talking about mainly is, for example, when in bipolar disorder, if we measure the incidence of depression versus mania or hypomania, depression is more prevalent, it's more common. So it's likely that if you diagnose someone with depression and they develop mania or hypomania in the future, then your impression will change from unipolar major depression to bipolar depression or a bipolar disorder, right? It could be changed to if you discover that there is an underlying medical condition that precipitated the presence of depression. Again, the diagnosis might change. Yeah, I found the notes here. So patients with bipolar disorder often suffer one or more episodes of major depression and initially receive a diagnosis of major depression disorder. So prior to their first manic or hypomanic syndrome. And there's a study here, a meta-analysis identified 5 longitudinal studies, more than 3,000, who were diagnosed with major depressive disorder. And the mean length of follow-up across the study ranged from 12 to 18 years, which is quite good time. Bipolar disorder was eventually diagnosed in 23%, almost a quarter of these patients. The diagnosis were changed from major depressive disorder to a bipolar disorder. Yeah, that's what I was looking for, is this study. Now, the probability of switching diagnoses was greatest in this study, was greatest in the first 5 years of follow-up, and was higher in patients with certain characteristic. And they put like younger age of onset of their first life major depressive episode. That makes them more liable to change the diagnosis in the future, which makes sense. If you have a family history of bipolar disorder, then that's make it more likely for a unipolar depression to change in the future to bipolar disorder. If there was symptoms that indicate psychosis, delusions, or hallucinations, then again, that might affect the diagnostic stability and coming up with psychosis in the future or schizoaffective disorder. Okay, so that's about the diagnostic stability of major depression disorders. And in fact, it's one of the most common diagnoses that can change in the future is major depression. Okay. Depressive episodes subtypes. We talked about different classification of depression, but we have some specifiers in the DSM-5, and the full diagnostic criteria would be major depressive disorder with the following specifiers: with anxious distress, atypical features, catatonic features, melancholic features, mixed features, with peripartum onset, with psychotic features, or with seasonal pattern. I will go briefly over the different specifiers and the required diagnostic criteria. Diagnostic criteria for depressive episode subtypes, and we'll start with the anxious distress. We need, in addition to presence of major depressive disorder, the presence of 2 or more of the following symptoms during most days of the depressive episodes: tension, restlessness, impaired concentration due to worry, excessive worry, fear that something awful might happen, and fear of losing control, self-control. And why is that important? Because sometimes we see that a lot, that people give or label the patient with more than one diagnosis. For example, in that case, if you have excessive worry, if you have the feeling that something bad is going to happen, or fear of losing control, you might add, although this is sub-threshold or only 2 or 3 symptoms apart from the required symptoms for a panic disorder, for example, but you will find that that patient was labeled with major depressive disorder, panic disorder, and we could easily put major depressive disorder with anxious distress. Atypical features, and we need at least 3. Reactive to pleasurable stimuli, and in fact, the first one, this feature in particular, should be present. At least one of the symptoms is mood reactivity. So meaning that these individuals will feel better in response to positive events. So إذا في حاجة يعني مفروض ينبسطوا لها فحيكونوا مبسوطين. So that's an 8 with major depressive disorder with atypical features, because people with major depressive disorder, usually their sadness, their low mood is persistent. Increased appetite or weight gain, rather than with the typical depression where we have loss of appetite and reduced weight. So they have more, we have the opposite. And then hypersomnia, where in the typical depression, we have difficulty sleeping, insomnia. Usually it would be difficulty falling asleep or difficulty staying or maintaining asleep. In atypical features, we have hypersomnia, sleeping at least 10 hours per day, or at least 2 hours more than the usual baseline when not depressed. And then the heaviness that they feel in their limbs. That's another feature as well. And there is long-standing pattern of interpersonal rejection, sensitivity, feeling deep anxiety, humiliation, or anger at the highest rebuff from others. That's another feature from the major depressive disorder with atypical features. Catatonia, this should be, we're not talking about catatonia in particular, but it should be major depressive disorder with catatonic features. And you will see the prominent psychomotor disturbances, whether increased or decreased activity, in addition to the other catatonic features. Melancholic features are characterized by at least four or more of the following symptoms. Again, loss of pleasure in most activities, because we know that this is a form of more severe depressive episode or depressive disorder. Unreactive to usually pleasurable stimuli, so they do not feel better in response to positive events, and that differentiates them from the atypical depression, but with the atypical features that we talked about. A depressed mood marked by, because it's a form of a severe depression, so we have a profound despondency, despair, gloominess, and early morning awakening 2 hours before their baseline, and psychomotor retardation or agitation, anorexia, weight loss, and excessive gulp. Mixed features, unipolar major depression and persistent depressive disorder can be accompanied by subthreshold, so meaning that not meeting the full criteria for symptoms of hypomania or mania. So you have so you have the same symptoms for mania and hypomania, but just you're not meeting either the full criteria, the required number of symptoms, or the time criteria. They're less than the 4 days or a week that is required in cases of mania, but the symptoms are there. And it could be elevated or expansive mood, inflated self-esteem or grandiosity, more talkative than usual, or pressure to speech. And we see that a lot. You see a depressed people, but when you ask about a depressed patient, but when you ask about previous history of mania or hypomania to rule out bipolar disorder, they will tell you about some days when they feel like elevated or on top of the world. There's some grandiosity there, maybe some overspending, but that's it. There is no other list of symptoms to meet the required number of symptoms to diagnose mania or hypomania. Or even if they meet the number of symptoms, but they don't meet the required time. And that's where you can put major depressive disorder with mixed features. Okay. We have also peripartum onset. Peripartum onset refers to mood during pregnancy or within the initial period after delivery, which is usually 4 weeks. And then major depressive disorders with psychotic features, when you have psychotic features, whether delusions or hallucinations. And then major depressive disorder, seasonal pattern. Seasonal pattern refers to a regular time relationship. There is a temporal relationship association between the onset of major depressive episodes and a particular time of year for the past 2 years. And remission also occurs at a specific time of a year. Yani their depression might begin in winter and they're okay in summer. And that's the usual thing for them. In addition to that, the lifetime number of seasonal episodes substantially outnumber the non-seasonal episodes. Otherwise, you would call it just major depressive disorder. I think we'll leave that now. And Yasser, I don't know if this is the just 5 minutes to 50 minutes. I don't know if there is any question now, so we can.
And I think we can leave the questions till the end.
Okay. Okay. So, so since I have, this is the main thing that I want to present, but I would go over the management. So, and I don't think that 5 minutes would be enough, but we'll just try to go quickly over management. I didn't prepare any slide for that, but it's fine. So management depends on, so when you diagnose depression, you want to, as we mentioned earlier, the most valuable thing is your initial encounter with the patient, the initial interview. You want to collect as much as possible information, diagnostic criteria, and we mentioned that. You want to rule out other possibilities, substance use. You want to rule out other medical conditions, and so forth. You want to talk about, ask about family history, because that's it could be like a biological marker, a biological test that will help you initiate or choose what medication to start with. Because if they have a first degree relative who had depression and they improved on a certain medication, and instead of just randomly trying an SSRI per guideline, you could go for that medication. So family history is important. You wanted to look for their medication adherence as well. So, and you could easily know that, especially with patients with other comorbidities. So if they have diabetes or they have high blood pressure, and you can see that from their lab results, physical examination, that their blood pressure is under control, their blood sugar is not well controlled. And you ask them after that, and then you reach the point where compliance is questionable. You might, and you want to start an antidepressant, so you wanted to start something with a short half-life rather than, a long half-life rather than a short half-life, because you know from your history that there is some compliance issues. So these people might take the medication for a month or two, and when they start feeling better, they might stop taking medication, and giving them a short-acting antidepressant might increase the risk of discontinuation syndrome. That's another issue. You need from your initial assessment to look for other comorbidities as well, as we said. So if you have a patient with a neuropathic pain or any kind of chronic pain, that will affect your management plan, because certain medications can be used for both, to manage pain and as an antidepressant. We'll talk about that in a bit. Other comorbidities are if they have any sort of eating disorder, especially like binge eating, which is common with depression, and there's a high association comorbidity between the two. If that's the case, then there are some particular medication approved to be used in binge eating disorder and depression. From substance use angle, if they're heavy user, heavy smoker, and they're willing, from your assessment, they're willing to stop using, to stop smoking and they're motivated enough to quit smoking, then you might use a certain medication that help them with smoking cessation, and at the same time has some mood elevating activity to help them with their depression. So management part starts when you start your assessment. Even by taking the history, you're starting the first step in managing the patient afterward. And then it depends on the severity of depression. So for mild depression, you wanted to, first of all, it should be always a shared decision between you and the patient. So this is my impression that you have a depressive disorder. It seems to be mild. We have these two options. We can start with talk therapy, psychotherapy, or medication. There is no one superior to other, and that's we're talking about now about mild depression. There is no one higher. You can start with this or that. However, psychotherapy, it might take, it's not available. Sometimes it's hard to find someone to connect with. It's more expensive if you're not covered. It might take longer time for you to learn the required skills. And I'm talking here about if we're starting CBT, cognitive behavioral therapy. But the advantage of that it's lifelong skills. So relapse might be less likely if you had a good grasp of the required skills, and there is no side effects with psychotherapy. On the other hand, however, the onset of improvement might take longer, right? On the other hand, if you want something, we have medications as well. They start quickly, generally. They have good response. Sometimes, however, we may need to change the medication and play around until we reach a good medication that works for you. And there are some side effects. Some of these side effects are minor, like headaches, GI upset, and that usually they go away within a week or two. And you don't need to worry about them unless they're so severe. However, we have some other side effects that may persist. And we're talking mainly here about sexual dysfunction, which is so common with SSRIs. So that's another part when you look over the assessment, the first assessment, that there is a comorbid sexual dysfunction. That's something to consider when you come to the management part as well. So all of these factors plays an important role in management. So that's for mild depression. So let's say the patient wanted to start with medication. Medication we have, SSRIs, first-line treatment. But again, if you have an indication to start, theoretically, okay, let's go back a little bit. We have the SSRIs, we have the SNRIs, TCAs, which are not used commonly now or less frequently used. We have atypical antidepressants that include medications such as Bushra or papropion, mirtazapine, agomelatine, and trazodone. All of these are considered atypical antidepressant because they don't fit in the other medication classification. MAO inhibitors are not used as well now. We don't see that much. So the main is SSRIs, SNRIs. Theoretically, SNRIs, because they work on both serotonin and norepinephrine. In real life, we see all of that people sometimes respond to SSRI, but not to SNRI, and so forth. So it depends on all of the other factors that we mentioned But generally, people start with an SSRI. SSRI, we have a long list of SSRIs like fluoxetine, citalopram, escitalopram, fluvoxamine, and so forth, paroxetine. You can start depend on their side effect profile and the patient presentation. So if you wanted to start with an SSRI, you have compliance issue, for example, as we said earlier, and you wanted to avoid putting in your mind that this patient might stop the medication at any point. You wanted to use a long-acting SSRI, and that would be the fluoxetine, which is the longest acting among antidepressants. If you have someone with, as we discussed here, with the atypical symptoms of hypersomnia, hyperphagia, they're eating more, they're sleeping more, and you need something to activate them. And it's not sedating, and they will not gain weight. It doesn't stimulate appetite, doesn't increase appetite. Then fluoxetine is a good option as well, because it's more activating. And in fact, many people report weight loss rather than weight gain, reported with the other SSRIs. So fluoxetine might be a good option. Remember when we talk about the binge eating disorder, again, fluoxetine is the one indicated with, FDA indicated with the binge eating disorder. However, the dose is a little bit higher. We may need to reach to 60 milligrams, but again, as the general rule, we have to start low and go slow. If you have a comorbid condition like OCD and you wanted some medication that you can maximize the most and increase the dose, again, fluoxetine might be a good option. So you go to 60 or 80, which is sometimes used in cases of OCD, which is higher required dose than the regular dose for depression. So it's really depends on multiple factors, but this is one of the medications that can be used. On the other side, it might be risky to use it on, given that this medication has a longer half-life. It might be more risky to use it with or in people with multiple medications. And that's typically in the elderly with a lot of comorbidities. But again, it's not by itself. It's used in all age groups, including children. On the other hand, the other SSRI that's used frequently is escitalopram, and escitalopram shorter acting compared to Prozac. Escitalopram has the lower or the lowest side effects profile compared to in terms of drug-drug interactions. So if you in an elderly, if you're worried about drug-drug interactions, using a low dose Cipralex might be, or escitalopram might be a safer medication to start with. Paroxetine, if you have insomnia, you want something sedating, might be a good option. Fluvoxamine is a very short, so it might be risky to be used in someone that you're predicting they can stop their medication, so more likely discontinuation syndrome with people on fluvoxamine. On the other hand, the other group is SNRIs, and the SNRI group we have. Am I okay, Yasser? Or
well, no, we're hitting time.
No time?
We exceeded an hour.
Okay, so Do you want me to stop here and wait for if there's any questions, or?
And I think we can, and if you have a point that you want to finish, I think we can get to that, but then we can go to questions.
Okay. So with the SNRIs, so serotonin and norepinephrine reuptake inhibitors, we can list of medications that we have in this categories. We have the venlafaxine, this venlafaxine, we have the loxetine, we have the milnacipran and then levomilnacipran. That's around 5 medications. Interestingly, for this medication to work as an SNRI, you need a higher dose. So you can't start someone, for example, on an SSRI, and then they don't work. And then you shift to an SNRI and you start. Of course, we have to start low and go slow. That's the golden rule. But you don't expect improvement, or you don't expect the medication will work as an SNRI for venlafaxine in doses like 37.5 or 75. You have to go higher than that, because at a dose lower than 75, they stimulate serotonin reuptake, but not the norepinephrine. They still SSRIs, so you have to go higher. The maximum dose is 225, but sometimes in inpatient settings with severe depression, we might need to go up to 375. That's the maximum for inpatient antidepressant dose. While the other group, same way for the this venlafaxine, which is a prodrug or active metabolite of venlafaxine, same way we have to go higher. The dose is 50, maximum is 100. The loxetine, but the loxetine, there is more evidence for pain, which is venlafaxine too as well, but the evidence is more for the loxetine in patients with fibromyalgia or chronic pain in general, and neuropathy that comes with diabetes. That's an indication as well, and some people will go for that as the first option compared to SSRI. For the milnacipran and levomilnacipran, they're more of norepinephrine blockers rather than the serotonin. So if you want to have the SNRI effect again, you have to go higher with the dose. Sometimes in certain situations, we might prefer to use an atypical antidepressant. Well, for example, in case of smoking cessation, we want to make sure that we can use one medication that can benefit the patient in 2 ways: help with the smoking cessation, and it's an antidepressant, although it's weaker compared to SSRIs, SNRIs. And one of the things that you should be careful about in case of Wellbutrin is it can cause insomnia. So it's better to be used in the morning, and it's not good with people with insomnia at the beginning. It doesn't cause weight gain, which might be a good thing for many patients, and it has less or no sexual side effects. It's always hard to say no, but safely to say less side effects, sexual side effects, which is common with SSRIs and SNRIs. We have to be careful that the patient has no previous history of seizure, and that includes not only diagnosis of epilepsy, but in people with eating disorder because of the electrolyte disturbances, they're more prone to develop seizure as well. So that's the main contraindication. Not the trazodone, it's an atypical antidepressant, but mostly used 50, 100 milligram, which is usually not a good antidepressant dose. Antidepressant dose start from 150 up to 300. but the 50 or 100 usually it helps with the sleep, and we see that all the time it's used to aid the sleep. And we have to make sure in elderly population, because it can increase QTC prolongation, especially with the higher dose. Mirtazapine is another atypical antidepressant, but the main side effects are increased weight gain, increased sedation, and sleep. So it would be a perfect option for someone with insomnia and loss of appetite. That's why sometimes used in elderly with lower dose. And again, it has less sexual side effects compared to SSRIs and SNRIs. Sometimes we need to combine medications. Several studies, like we know about the venlafaxine plus mirtazapine for treatment-resistant depression, if we fail two different treatment, usually from different classes, or augmenting with antipsychotic, like the most commonly used quetiapine, especially if we have problem with sleep. Abilify is used as well if we're avoiding metabolic syndrome and weight gain. Rexulti is also used, and I think now it's approved as a monotherapy for depression as well. The problem is just the cost of the medication.
I think we might need to stop.
Okay, thank you.
All right. شكرا جزيلا Bushra على presentation. Is very comprehensive. The topic is big to be covered in an hour, to cover all the aspects of depression, from the clinical presentation لحد ال clinical judgment about choosing medication. Just in 1 hour, it's a very comprehensive topic. وفي الآخر presentation, it's an introduction للtrainees ولأي زول to think about the discussion, وبعدين to bring questions في discussion. الدiscussion هنا بيكون ساعات more useful، يعني very useful كمان، very useful part، غير انه يعني على عكس انه واحد يمشي يقرا بقى. Just انا افتكر بس عايز ازيد one point، افتكر في حبه questions هنا، لكن في one point انا عايز ازيدها، اللي هي في الدياجنوز بتاع الديبريشن. The lines between normal and abnormal seems to be very non-specific. اللي هي عشان كده احنا مثلا how to differentiate depression from sadness. ما حاجه مثلا الواحد بيقدر يعتمد عليها، there is subjectivity. How to differentiate depression from grief. Yes, احنا حبينا نعمل مثلا الليله criteria عشان نعملها more objective، لكن grief can be a very complex process، والليله وعشان كده ذاته في ناس بيكون عندهم depression وgrief complicated by depression. Lines between what is normal versus abnormal ما very clear في psychiatry. عشان كده مثلا عشان to bring some يعني context للموضوع ده، ليه تفتكروا الزول مثلا جاب الفكره بتاعت why do we have to add 2 weeks 2 weeks في الاخر عشان to help us to differentiate between، او في الاخر دي it's not يعني classical to differentiate between what is normal and what is abnormal، بحيث انه مثلا الليله يعني hypothetically انه الواحد he should be sad only for days, week. The likelihood that this is extended to a longer period of time, the more likely انك you're dealing with a pathological process. هي دي ما definitive، لكن it helps us to kind of to clear the bar for a diagnostic standpoint. احنا we're trying to be objective، لكن دي ما clear عشان بس في الاخر الناس ما تعصش طوال. Yes, if you follow the diagnostic criteria you have to go with 2 weeks، لكن ما تعصش with 2 weeks. It can be, you can truly have depression in less than 2 weeks. تاني حاجة اللي هي ال diagnostic criteria بتاعت depression according to what we know based on the DSM. دي الناس تفتكر يعني ما يزول يعني شنو هو انت you can have other symptoms. عشان كده احنا عندنا ال other specifiers دي، الميلانوكوليك والكيراتونيك والاتيبيكال، لانه not everything is going to follow the DSM. ال DSM عباره عن بيقولوا عن index criteria for depression. يعني في الاخر انت you might have depersonalization, you have sense of numbness. Numbness is not part of the diagnostic criteria for depression، لكن you can be depressed. Lack of reactivity صحيح ما part of a classic criteria for depression، it is part of depression. An anxiety ما part of diagnostic criteria، لكن احنا بناخدها it's important. هم الليلة عشان to choose a diagnostic criteria they have to choose يعني a criteria to have to be sensitive, specific and practical, easy to recognize. فانت في كميه من السايكوباثولوجي under depression they chose الحاجات دي to represent depression. But they're not only the depression is not only these features. They can more than this be more than these features. This is my point just to add. في questions يا بشرى ليك؟ First question جاي من دعاء. My question is about resistant depression. I came across patients who have tried different kinds of antidepressants throughout the years, and they will say they did not find desired effect. Some will respond to a specific antidepressant, then they relapse, and then they report medication stopped working. What are your recommendations for these kinds of patients, especially when I'm working in a setting when psychotherapy is not available? Major thank you for the organizers. Dua.
Yeah, thank you, Joa. Yeah, we didn't have the time to talk about treatment-resistant depression. Like, if you used enough medication, different combination strategies, a different augmentation with an antipsychotic, and there is no response, then it's always helpful to augment that with psychotherapy as well. Like in زي ما قالت دعاء, if it's not available, then it's not available. Then you have to go for the other resources, like or other options, ECT, TMS, and so forth. Sometimes lithium can be used for depression. في حاجة اللي هي مهمة إنه لأنه دعاء ذكرت إنه I think somewhere some people they say medication just to stop working. It's always important to consider the natural course of depression. عشان كده natural course of depression is up to 6 months. إذا أنت في زول depressed وما اديته أي علاج, ما عالجته خالص, you don't expect that they will remain depressed to the end of their life. At some point they will be okay. فعشان كده التغيير في التريتمنت quickly مشكلة. تلقى زول إنه مثلا أخذ بدل حبوب, lack of psychoeducation, ما provided the enough information, المفروض ياخذ كم, increasing the dose, and then for how long, what to notice in terms of symptoms improvement. And after a week or two, you change to another medication, and you change to a third medication. حتصل مرحلة معينة لما تستخدم الدواء الرابع أو الخامس, and then the patient will improve, and then you don't know if this the medication that you use, if this the natural course of depression. Just خلاص بقى كويس من غير أي حاجة. فعشان كده دي النوعية اللي ممكن يجيك بعدين ويقول لك والله أنا أخذت نفس الدواء قبل كده وكان ممتاز, لكن هسه ما عمل أي حاجة. So maybe it was that. Anyway, that's something to consider as well. لكن في ال other options اللي هي ال ECT, وحتى ال ECT sometimes you need a maintenance ECT after you complete the whatever مثلا 8 or 12 sessions, and then you need في ناس بيعملوا انها تكون once weekly, then every 2 weeks, then monthly, then ويستمروا على كده every month if they need maintenance ACT. TMS is also used. في now the use of ketamine is ketamine, but it gives like very short. It acts very fast. لكن برضو I have seen patients who relapsed on these medications, and we have to go back on trying different antidepressants. It's not an easy thing, لكن you have to always rethink about your diagnosis. Maybe the diagnosis was wrong, or you missed something. Or remember when we talked about the diagnostic stability, maybe there is something new that you need to address as well. Medication compliance, social situation, family support. Depression it's really big, and we have to نشوف كل الحاجات دي to say that there is no response to treatment. That's what I can say.
في سؤالين. يعني السؤال الثاني هنا in the case of bipolar affective disorder, if we have a patient in a maintenance phase and taking only sodium valproate who develops symptoms of depression and antidepressants is to be prescribed to avoid switching, is citalopram preferred compared to fluoxetine?
Right. So هنا طبعا there is no so في guidelines wise ما في يعني there is no indication in guidelines in somebody with a known bipolar disorder there is no place for using antidepressant. Clinical practice is different. You can see that all the time. These people are known to be bipolar disorder people and they're on different antidepressants. So I don't know why you choose citalopram compared to fluoxetine. Like, I have seen people using different things. Like, the best thing would be either increasing the dose of because valproic acid is a good medication for bipolar maintenance therapy as well. Maybe the dose is low, maybe checking the valproic acid level. Maybe the patient is taking another medication that's affecting the valproic acid level, especially if at some point was an oral a female oral contraceptive or combined with lamotrigine, for example, because it can cause fluctuation in valproic acid level, or using a different mood stabilizer, and that could be an antipsychotic with a mood elevating effect. Aripiprazole, quetiapine, which is good for, there is a high evidence for quetiapine for bipolar depression. So that would be a good medication to use rather than using an antidepressant with the risk of switch to mania.
وعندك سؤال من just a second here, دعاء عبد الرحمن. Thank you so much. Is it true that people might develop some sort of desensitization to antidepressants?
Again, that's something that you cannot really measure, but you see all the time. بيقول لك إنه إحنا كنا بناخد الأدوية دي لكن now it's not working. So several factors يعني could be blamed here. زي ما قلنا إنه is it just the natural course of whatever underlying illness? Is it diagnostic stability of the disorder? يعني هل في حاجة تانية? Maybe there's something else. Is it a compliance issue? لكن you can't really see 100% there is a lack of effectiveness of that medication for that person, because يعني واحد من الحاجات اللي احنا بنقولها في patients as part of the psychoeducation, these medications, yeah, they have side effects, but they're generally safe. They're not habit forming. They're not addictive, right? So we need to check everything else.
Afaq عندها question about the choice of antidepressants for a patient with epilepsy.
Right. With the epilepsy, SSRIs are generally used safely. Even the SNRIs are used. The concern would be using an augmentation with an antipsychotic, because كل antipsychotic can lower the seizure threshold. So in that regard, you have to be careful. Although augmentation strategies for depression, usually we use much lower dose compared to antipsychotic dose. But that's something at the end, it can, you can see always, بالذات إذا كنت يعني psychiatrist started the antipsychotic, and then هنا مثلا بتكون الفاميلي physician after that will follow up the patients and they can increase the antipsychotic dose even further. Which will not be good for depression. For example, Abilify or the aripiprazole, to augment with an antidepressant for treating depression, you need 2, 5, 7, maybe 7.5, less than 10, which is the lowest antipsychotic dose. And that's the required dose below 10 to help improving depression. However, if you increase the dose above 10, actually it might worsen your depression because it will block dopamine. Dopamine is low, and then you can expect that will affect the depression negatively. So there is the reason why these antipsychotics at lower dose.
I just can add to برضو الquestion بتاع epilepsy. هما a well-known medication that can increase the risk for seizures, or basically they lower the threshold for seizures. Tricyclic antidepressants generally.
Right.
The risk is almost double. وبعدين البيبروبيون ما على normal dose. البيبروبيون بيجي في several doses as an antidepressant. بيجي في 100, 150, 300, 450. Into the moment you start exceeding 300, the risk goes up. At a dose of more than 450, the risk can go up more than 10 times. عشان كده it's risky, لكن relatively risky. At a lower dose, it's not that risky. لكن at a higher dose, it is risky. الباقي ال SSRIs, they're safe. يعني هم الريسك بتاع ال SSRIs is very close to the risk in the normal population. وفي سؤال من إيمان بتسأل عن ال options. I think you tried to answer this in the middle several times. اللي هي ال use of adjunct treatment options for antidepressants besides antidepressants.
Yeah. يا اللي هو قلنا يعني في سؤال ثاني ولا؟
لا هو بتسأل الاوبشنز بتاعت افتكر الادجunct treatment. You mentioned the antipsychotics, mentioned lithium already.
Yeah. Yes, lithium can be used. Sometimes we use other like low dose of even when the thyroid function is normal, we can use a small dose of thyroxine. Vitamin D, although there is no evidence for that, but can be used. There is no clear evidence. There are some papers about that, vitamin D and role of vitamin D deficiency in depression. But the main strategies would just combining antipsychotics commonly used. Again, the quetiapine, the Rexulti is very commonly used now, pixiprazole and aripiprazole. But people used all kinds of different antipsychotics. The main exception that we don't use that as a medication is haloperidol, because it's kind of depressogenic. It can induce depression by itself, in addition to the other extrapyramidal side effect that it has. Combining antidepressant, sometimes used. The main thing, as I mentioned earlier, the mirtazapine with the vanilla vaccine.
عندك question هنا وفي ناس مؤيدين الquestion ده كتير اللي هي generally how can we protect ourselves from depression in our life من ندى.
والله يا أخي يعني أول حاجة ربنا يعني تصلح حال البلد. أول حاجة دي the most يعني depressing thing now. لكن يعني that's something that everyone else can add to it. لكن I think life balance is the most important thing. يعني have time for yourself. Don't overwhelm yourself. Sleep well, eat well. اللي هي الحاجات اللي دائما احنا بنقولها للناس لكن ما بنعملها. لأنه level of burnout, especially among physicians, is very high. يعني reasonable workload, time for yourself, time for your family as well, and time for yourself, time مع الفامily مثلا. That's something we don't take time for ourselves, and that's something that we need to do And I think one of the strategies is always self-reflection as well. So every day, if you just make it as a habit and you self-reflect on daily basis, what did you do yesterday? How do you want it to do it better? How you can do it better tomorrow? That is a very important thing that we don't do usually as well. لكن that's a huge topic, I think. كل زول حيكون عنده something else to add.
And one last question, Alihia, what is the role of magnesium citrate in treating depressive symptoms or depression symptoms?
There is a role in magnesium during sleep. There is few papers about that. لكن المشكلة now يعني في الإنترنت ده لو فتحت أي حاجة حتلقى رول لأي حاجة في أي حاجة. That's a problem. Improving sleep can improve depression. زي ما اتكلمنا قبل شوية عن vitamin D and depression as well. يعني في few papers, good papers, linking low vitamin D level to depression. But there is nothing to prove that using vitamin D will help as a treatment for depression. Yani, that's why some people, they just combine that as an augmentation strategy, but there is no like as standalone treatment for depression with vitamin D, even with people with vitamin D deficiency. So I don't know, that would be the short answer, but I don't think that there is an evidence-based role in using magnesium alone in treating people with depression.
أنا كومنت لفاطمة. أنا شفتي الأسئلة اللي زي دي I like it لأنه this is exactly what we're looking for the journal club. When you hear about a new information about the medication, we don't know the level of evidence, and you're interested, this becomes a question for a journal club for the future. You go and look in the مثلا you look for a study, and بعدين مثلا نمسك الستدي اللي they shared the concern, shared a benefit of the use of, let's say, magnesium citrate. And that becomes more of a topic of critical appraisal of the literature here. This is exactly the main reason why we have a journal club. For it, like, I mean, when you come up with across a question like this, and I like the question. I don't know exactly if there is a role or not. في questions ثانية وافتكر بعد شوي عشان نختم. في question مهم هنا اللي هي if a patient has a family history of bipolar affective disorder and presented with depression for the first time, should I start him or her on a mood stabilizer plus antidepressants?
معلش يا ياسر ما سمعت الجزء الأول.
نتكلم عن patient who has a family history of bipolar disorder, and the patient presented for the first time with depressive symptoms for the first time, no manic symptoms, no mixed symptoms. Should we start the patient on antidepressants and mood stabilizer with antidepressant?
No, I would go, yeah, that's an excellent question. I would go with an antidepressant, but that patient needs to be very careful in starting the antidepressant. Let's go back a little bit. You have to make sure that there is no evidence of mania or hypomania in the past. I mean, you check carefully for symptoms because you know that there is a strong family history of mania here, but that doesn't mean that this patient will have bipolar disorder for sure. That's the first thing. The other thing, you start with the antidepressant, but you start low, maybe lower than the usual, and monitoring him, follow up more than usual, and provide him with the needed information that he has a history of developing mania or hypomania, and explain to him what is mania, what is hypomania, what do you need to know, what do you need to do if you developed one of these symptoms, and just continue monitor him. But otherwise, I wouldn't recommend starting a mood stabilizer just because you're expecting maybe he will develop bipolar disorder. No.
While you're being cautious في الآخر, and
yeah.
just even something shows up, طوالي أنت توقف.
Right.
One last question. This is last question. Is there a need to treat patient with subdiagnostic or subsyndromal criteria for major depressive disorder?
What do you mean by the question?
somebody who presented with depressive symptoms yet not meeting the diagnostic criteria for major depressive disorder, is there any need to treat them ولا لا?
Okay, we didn't talk about that, and yeah, ده واحد كان من الكلاسيفيكيشن اللي هو unspecified depressive disorder وفي specified depressive disorder. الفرق بيناتهم إنه specified depressive disorder when you have someone with who has some depressive symptoms, criteria, but they don't meet the criteria, and you know why they don't meet the criteria. السبب يكون مثلا لأنه there is no enough symptoms. So you put major depressive disorder, unspecified depressive disorder, you put it between brackets, they're not meeting the required number. And the unspecified, إنه أنت يكون in let's say emergency situation, يعني في emergency department, you don't have enough time زي نحن ما بنعمل psychiatrist, يعني take all of that time to assess the patient. You know that there is some symptoms of depression, but you don't know what is missing. You can't specify. It's not because of time or duration. You don't know because you don't have enough time. And that's unspecified depressive symptoms. That for the unspecified, it's just because of lack of time. So you want to provide a full assessment to reach whether this is truly unspecified, but at the end you don't treat. That's not an indication for treatment. لكن خلينا نرجع وده الكلام اللي قاله ياسر هنا قبل برضه يعني at the end these 2 weeks criteria ما دي خدتوها ناس يعني إنه they measured إنه most people when they reach that cutoff of 2 weeks that their depression, it means إنه it will take longer time and they need help. لكن ما في حاجة بتورينا إنه مثلا اللي عنده depression for 1 week ده it's not going to be the same as 2 weeks. ومعناته إنه أنا أتزول جاني في خلال أسبوع أقول له just go back and come back home or come back to me when it's 2 weeks. Sometimes we need to treat and use that clinical sense. But at the end, we have to have our guidelines, and this is our guidelines. We have this 2 weeks criteria. Same way, the perfect example would be the heart rate. The normal pulse rate, less than 60 is bradycardia, more than 100 is tachycardia. This study was based on military-based individuals, يعني كلهم young age. I think when the maximum was 24, kind of 2,000, and the majority of them in the heart rate between 60 and 100. But that doesn't mean if you have someone with a heart rate 55 that they're going to die or there is something serious is going to happen. But that's the general criteria, right? So that's what I mean. And to تعالج ولا ما تعالج بتعتمد على your evaluation, your clinical sense, maybe close follow-up, close monitoring, let them see you again, and then you decide. But at the same time, we don't want to medicalize everything. And we talked about grief, normal sadness. يعني we don't أي زول ده بحب التاتش كده إنه they might be depressed, let's start an antidepressant. It should be a genuine assessment that warrants treatment. That's what I can say.
All right. Thank you very much. And I think we end up here. Thank you very much, Bushra, at the excellent presentation here. I'm going to stop the video. Okay.